I'm Courtney. I kind of did a little bit of an introduction, so there aren't new people here, but so state training administrator, also a paramedic with an agency up in the northern part of the state.
And I'm Mike Ranzio, again, the Deputy Chief for Chester Ambulance and a paramedic as well.
Mm-hmm. Yeah, so this is just kind of the session description that you all read. The whole point of this, I hope that you'll stop and ask questions just as we did in the previous presentation. This is absolutely a small enough group where that will work really well. But we want to shed some light on shifting a little bit from stroke now to dementia specific. We want to shed some light on how EMS plays a role in the management of dementia patients in our communities. So by the end of this, we hope that you'll have a general understanding of the education that EMS clinicians go through to be able to help our dementia population, and then also understand what we can do for people specifically. And then in addition to that, there will be a question and answer time, and I'm really hopeful that some people in here will have some suggestions either to how they've cared for patients in the field or to other resources that they feel educators could utilize in course settings.
So kind of starting off, we love acronyms. Everything's an acronym in EMS, right? So EMS stands for Emergency Medical Services. And then under that umbrella, we kind of have 3 national certification levels. So we have the EMR, which is the Emergency Medical Responder. We have the EMT, which is the Emergency Medical Technician. Advanced EMT, Advanced Emergency Medical Technician. And then the National Registry Paramedic. There are some specialty certifications that they can hold as well, but nationally those are the 4 most common. The other acronyms we kind of use is IFT or interfacility transport. So you kind of heard at the end of the last one, we were talking about the struggles of going from one hospital to another hospital. Both EMR and EMT fall under what we consider basic life support. So they have the basic training on how to kind of do simple interventions to help sustain somebody. And then the advanced EMT and the paramedic are advanced life support. So now we're starting to get into invasive procedures, advanced airway procedures, and medications.
All right, so when considering patients with dementia, where might an EMS provider come into play here? So one environment, that IFT, the interfacility transfer. So if you have an individual who needs to get from, say, a hospital to a nursing home or a nursing home to a hospital, that patient may rely on an ambulance service with EMS clinicians staffing it to get them from point A to point B. So this is not necessarily a 911 situation, though there are times when it is an emergency, but a lot of times we end up kind of just being that transport. But we still need to have time, we still have time to get to know the patient, and for someone living with dementia, they may be confused as to why we're there. So knowing how to navigate those conversations to make them comfortable is really important. And that's something that we go over a little bit in classes, but we'll get into that as we go here.
And then obviously, right, we respond to 911 emergencies, right? That's probably the biggest one that we do. That's what we all, like any agency in the state of Vermont, when they have a license, we all agree to providing 24/7, 365 911 services. Interfacility transports is more of an optional thing for agencies. Not every agency in the state does that. I think that one's the most self-explanatory.
Yeah, that's the one where we show up in your living room.
At 2 o'clock in the morning.
Yeah. So EMS, what exactly do EMS clinicians get taught about dementia?
You guys have any thoughts about that?
Yeah, actually.
How much do you think we get taught about dementia?
Oh, 0.
Well, there you go. We really get taught nothing.
Wow.
The very bare minimum, right? Most of us understand dementia as memory loss, and that's the extent of our understanding of it. And then we'll go into it a little bit more later, but even our protocols don't even really mention dementia at all.
Okay.
Yeah, so.
Yeah.
So in Vermont, we follow what's called the National EMS Education Standards. And so this is a set of education standards that was developed by many brains in a room, lots of doctors involved, educators involved, to come up with what can we expect different levels of an EMS clinician to know. And so this is specifically the psychiatric and behavioral emergencies portion of the curriculum. There is a section for many, many different things, but you can see here that for psychiatric or behavioral emergencies, the EMR, right, that emergency medical responder is BLS. The EMT is also BLS, so that's basic life support. And then we have our advanced EMT and our paramedic, those are ALS, advanced life support. So just from this alone, you can see that BLS is responsible for a little less information than the ALS provider. But the ALS provider also comes with some more assessments and treatments that they can give for patients. So you can see here the EMR, I'll let you read some of this, I'm not going to read everything, but in the state of Vermont, the majority of our providers, a large majority, are licensed at the EMT level, and then the AEMT level, and then paramedics. So now we do have quite a few AEMT providers too. So a lot of, like, AEMTs are more readily available than paramedics right now. But we do teach our BLS providers that if they see that there might be a need for further interventions that they can't give, they should call for an intercept. They should call for an ALS provider. So as you read through these a little bit, just glance through them, the word dementia or Alzheimer's or any of the diseases that fall under the umbrella of dementia are actually not mentioned. The closest one here is acute psychosis, which you could have dementia-related psychosis, right? And oftentimes that is why we're called in a 911 situation for somebody. And so we do teach about what someone having an acute mental health episode would look like, and we usually relate it to potential of having hallucinations and delusions and how we can talk patients through that and family members and such. So this is really kind of what we, like the general topics that we're taught, but then this, is the wrong button.
So, right, simplifying it a little bit more, right? Across all the levels, we do have a level of training to assess the patient, right? That's kind of our biggest thing. It may not be very fine-tuned towards recognizing dementia or how to handle it, but with every call, we do an assessment of some sort. We also, across the board, we have verbal de-escalation skills. It's both taught in-house. There are some education programs out there that can help expand those skills. But that's probably one of our most powerful tools, is our voice, right? Now, again, resource management, making sure we have the right resources, right? In the state of Vermont, a legal crew to transport someone consists of an EMT at least, and then an EMR, or what we call a Vermont Emergency First Responder. That is the minimum required crew to transport. So it may be that that EMT identifies they need more help and they're going to request for an AEMT or a paramedic. Moving on from there, we have physical restraints. Now, in my head, I always kind of think of physical restraints as kind of a last resort. If you've ever done it, it is not a pretty process. And you feel horrible about it, right? Nobody wants to fight an elderly because they don't even know what's understanding, right? But for us, we see it as a safety risk, where it may be a safety risk towards us or the patient, and we're trying to help them. So EMTs, advanced EMTs and paramedics can do that. And then the last thing we have at the paramedic level is pharmacological interventions as a restraint form, right? So we'll go into the protocol a little bit more, but we do have some options, right? And we don't just go whipping medications out there. We have some other assessment things that we need to do to actually determine whether we can give a medication. And the other great part about our protocol is there's really like 1 or 2 specific times where we're not actually consulting a physician before giving a medication. Other times, If we think they may need a little bit of kind of sedation restraint, we're consulting with a physician at the receiving hospital. The only time we really wouldn't is if it's a safety risk, they're being combative and severely agitated. But again, we'll go into that a little bit more in a minute.
Yeah, so as you notice here, like Mike was saying, there's the assessment piece is available to all levels here. So when we're considering the exact assessments we use, the first thing that we're going to want to understand is why are we called here, right? So if we're called to somebody's house for a dementia patient, it's typically not the patient with dementia who is calling because they don't understand that anything's wrong, right? But it's a family member who's shown up to care for them or has been with them throughout the day and notices changes in their mental status. And so we want to understand where might that change be coming from. And quite clearly, someone who has dementia, that doesn't necessarily mean that that's the only medical condition that they have. So as healthcare professionals, we need to dive a little deeper and make sure that there isn't something in addition going on here. So this person could be experiencing, like blood sugar issues. They could be a diabetic, which can impact behavior, right? They could also be experiencing infection, so like sepsis, UTI, absolutely.
Probably the most common one.
Yeah.
They could be experiencing anything from like cardiac issues. They could even be in pain, and it's just coming out in this way that they can only express. They can't pinpoint it for you. So these are all things, we don't just automatically walk into someone who we're told has dementia and is acting not their self and assume, oh, it's just related to their dementia. We do know that we need to dive deeper.
One of my favorite things to do when I'm going to a known dementia person or Alzheimer's is before I even go and walk in and see the patient, if the family's there, I'll take a couple minutes to talk with the family and understand their baseline. So then when I walk in, I know kind of what baseline is, and then I can really start assessing like, oh, well, this is different from baseline.
Yeah, exactly.
Sorry.
Well, no, and that gives that space from the patient to kind of try to understand what you're walking to, which is going to give the best outcome. Sorry, my kid's school keeps calling me. Okay.
You can take it.
It's okay.
That's cool.
They can call my husband. They can call my husband.
Okay. I understand.
So then there's this Richmond agitation sedation scale, which is a part of our protocols, and we'll get into what are even our protocols. But that's part of our protocols, and it gives paramedics an idea of when they would treat using pharmacological restraints. And we do have a picture of the actual scale in here that we can go over for curiosity. Oh, there it is. I thought that was a little further.
So, right. All of us in here, I think, are probably at a 0, right? We're alert, we're calm, cooperative. As we go up, right, if you have a +1 score, you are kind of anxious, restless, right? That may be someone who's just in a car accident, kind of just, oh my goodness, what happened? That's kind of what you would expect, right? Then we go up to being a little bit disorderly, loud, almost kind of like that intoxicated behavior, right? Mm-hmm. Now the +3 and the +4 is where we really are starting to now think there may be a need for some kind of pharmacological intervention, right? If they're agitated, aggressive, making kind of threatening statements, whether it's about themselves or us, or even when they reach that combative point, that would be a time where we do want to do some type of chemical restraint to get them to calm down, to both protect us and them. These ambulances are not made for a bunch of people moving around or playing. So it's super, super important to us that we can keep that patient safe in the ambulance, right? And sometimes if we have that +4, that may be the time to do some sedation. Obviously though, right, we'd probably try some verbal de-escalation first. We're not just gonna be like, oh wow, they're flailing around, they're hitting the wall. Like, that does not instantly mean you're getting medication. We're gonna try to talk, we're gonna spend some good amount of time doing some verbal de-escalation. And once we reach a point where like, yep, we are not making any progress, then we'll escalate it.
So those are the assessments that we kind of think through. Now, what do we do once we've done the assessments? Where do we go from there? And so we do have this protocol group, or protocol book here, actually, that's kind of composed of thoughts from a protocol group. But so this is, I would click on the link, but this is a book full of guidance on what to do in many different medical and traumatic situations within the field. For all levels, from VFIR, the Vermont Emergency First Responder, to paramedic and critical care paramedic endorsements as well. So one of the protocols that we have in here is our psychiatric behavioral health protocol. And so this is the start of that. There's another page as well, but this EA here, that means it's for EMT and advanced EMT. This guidance is specific to EMT and advanced EMT. And just real quick to give you an idea of how this reads, this is the next page down, and this is paramedic guidelines around the same psychiatric calls. So a paramedic can do all of this plus their stuff, but an EMT and AEMT can do just all of this, but not the paramedic stuff. Okay, so if you read through here a little bit, there's really, there's a lot of talk about understanding what exactly is causing this particular behavior and treating that, and also treating the signs and symptoms of what you're seeing because of the behavior. And so there are times when you need to call med direction, specifically related to like suicidal situations, which isn't super, well, I shouldn't say that. I don't know exactly how common that is with our dementia population, honestly.
It's high.
Yeah, it is high. Yeah, that's really unfortunate. But so someone who is suicidal is technically altered mental status, and we can't leave them at home. So there's a lot of different resources that we have to get on the phone with, and because usually they don't want to go to the hospital either. So those calls can really take a lot of time to work through. And I tell people time is your best friend in these types of situations, because even if suicide isn't a part of it, but in psych calls, part of that verbal de-escalation is just giving time and space for that to happen. It's not like a turn and burn situation, which in the EMS world is like, get there, get the patient to the hospital, and get on to the next one. Like, you really have to take your time and be methodical with these patients. So you'll see that EMT and AMT can really do the same sort of thing, everything from the assessment to the de-escalation to the physical restraints.
So, right, we kind of talked about that Richmond agitation sedation scale, right? So you'll notice it's kind of like, we start seeing that come up again, right?
Let me see. Oh, okay. I want to make sure there wasn't one more.
Isn't there one? There's one where you don't need good control, isn't there? If it's like a plus 3 or 4.
Yeah, I think that's on the other page. It got cut off.
Okay.
Yeah.
Anyway, right? So right here we have like 4 different options for different medications, right? Depending on the patient, the situation, we can do IV. Obviously that has its own risk, especially if they're agitated and combative, like, pull out a needle and I'm going to try to go for this really small pipe while you're moving and we're all moving. Doesn't really work well, right? So we do have the option of also doing intramuscular, which I think any of us would probably that's our go-to, right? We'll do that, and then maybe we'll do an IV and try to work through the rest of the things. But all of these options right here is they have to be, this is just anxiety, so this is the +1, +2 range, right? The part that we're missing right now is the 3-4, which actually gives us the ability just to do it without medical control. But if we have somebody who's just really not comfortable, they're very anxious, and it's very obvious to us, we can contact medical control, talk with the doctor, and kind of see what they think, and if we're both in agreement, we can do a little bit of sedation. This doesn't mean that we are making them go to sleep, right? This is just trying to calm them down And we have the steps in place to make sure that if we give that medication, we're also monitoring their respiratory rate, all of their vital signs we continue to monitor even more aggressively because we did an intervention, right? This isn't like a one and done and we're off. There's actually been lawsuits about this, and for me, anytime a patient's getting this, they're getting what's called an end title, which we're monitoring on the monitor their respiratory rate and how well they're breathing.
I'm gonna hand you this for a minute. This is the third time. I'm sorry, I have to
Don't
take
be
this.
sorry.
Yeah,
You're
don't
fine.
take it.
No,
Yes,
yes.
take it.
Please, yes.
All right, so I'll talk about a scenario that I had. So I'm really small town, right? Chester, Vermont. We also cover Andover. Combined, we have a population of about 4,000. The caveat to that is our median age is about 60 right now. And it's rural. So we see all kinds of things. If I see someone young, I'm like, I forgot. Like, I only see elderly. So
What are you doing here?
yeah, exactly, right? But I had this gentleman, a basic level crew went out. He's a little bit of a frequent flyer. He has a history of Parkinson's, dementia, a couple other miscellaneous things. And I get a phone call. They want a paramedic. So I get on the ambulance. They actually meet me at the station because they had to pass it to go to the hospital. So that's what we call a paramedic intercept. And get in the truck. And I know him, right? I've transported him myself before. We have a good rapport. But something about today is just off, right? He cannot stay still in the stretcher. We can't even take vital signs on him. He's so agitated. He's kind of pushing at the providers as we're trying to do anything. Not intentional, right? It's not like he's like, oh, I'm gonna beat you up. But he's just, there's something going on, right? So this is a prime example of where we're at that 3+ or +3, +4. And he's a safety risk, right? He's kicking the back doors of the ambulance. He's getting his foot caught up in the, we have little handles on the back. His foot's getting caught in there. So I'm worried that he's gonna hurt his foot by, he kicks it, gets caught in there, and then can't get out of it. So we ended up doing a little bit of sedation, right? And again, he didn't go to sleep. It was just simply to calm him down a little bit, and it worked, right? So they brought him to the hospital. I think he spent another hour or so at the hospital. They did some tests. They realized he has now like a new level of anxiety, so they put him on some anxiety meds, and he's been fine since. But it was just that one time something happened, and it required a little bit of restraint.
Well, you said Parkinson's too, and oftentimes that can present in agitation and anyway, and hitting out, and same with.
Yeah.
Huh. Sorry.
And again, right, I've seen him 4 or 5 times before that.
Right.
It was just something about that day. And he needed a little bit of restraint, and we're still friends. He doesn't hold it against me.
I was leaving that open to be like, you can be mad at me now.
Yeah.
I can talk about it later.
Yep.
All right, so I just want to take a minute to walk you through, so it sounds like you were just going through a call that you've experienced, so I'd like to take a minute to walk you through a call I've experienced as well. And so I'm going to start right at the dispatch and go through like what I think about when I'm called to situations like this, and then how I manage the scene, and then ultimately what the care of the patient gets. So just as a disclosure, there's no protected health information in here. This is HIPAA compliant. So we were called to respond to an assisted living facility for a male who had had multiple falls that day. Okay, so this is what dispatch is. It's pretty vague. They only know what they know because they're getting a call in, right? So they can't see anything, and so this could be a million things right now. And it's my job to start to prepare to walk into anything.
And another thing to think about is with dispatch, at least right now, sometimes it's like 3rd, 4th, 5th hand information by the time it makes it to us.
Yeah, absolutely. And so you can go to the next slide. So what I'm thinking about before I even arrive on scene is it going to be safe for me to just walk into? From that dispatch, my assumption is I don't really have many scene safety concerns. And the fact that it's at a skilled nursing facility, I hope that they would have told us if there were safety concerns before we showed up, right? So then I consider what type of facility I'm going to, what time of day is it, what type of staffing might they have, what have my previous run-ins been with them, you know? And then what staff, are there gonna be family present? And then once I walk inside, once I lay eyes on that patient for the first time, what is my initial impression? Do they seem really sick? Or do they seem like, okay, they're calm right now, let's get an idea of what's going on here, I have a minute. So right off the bat, I'm communicating with the facility staff. I went up to them and I just said, hey, can you tell me like what's going on today? And I got this information that the patient has been pacing back and forth all day. They're in a memory care unit. They've been pacing back and forth. They've had a couple falls because they're getting really tired, or that's what the staff felt was happening. And they were really concerned that if they kept pacing into the night, it was about 1 a.m, not getting any sleep, then they're going to get more hurt, like actually physically hurt. And I was like, yeah, that is a fair consideration. And at this time, the family was on scene. So the patient's significant other, as well as their adult son, was on scene, hoping to be familiar faces, hoping to help the situation. These types of facilities, they really do a great job, but much like other places around the country, staffing can be a really big challenge. And so staffing consistently too can actually, lack thereof can have a negative impact on the care that patients receive, in the continuity of the care at least. So when I asked what medications the patient takes, they are able to print off a sheet for me, but that's about as far as we can get. So when I ask about past medical history, they print off the sheet and I have to read it from the sheet. And oftentimes they've just come on shift, so they're actually completely unaware of what has been going on with the patient for the day. So these are all barriers that EMS really has to consider when managing the population. So then I turn to the family and I say, hey family, does your loved one seem to be acting normal to you? And of course, in this case, they said, no, he's really agitated. We're not really sure what's going on. Maybe I can get him to calm down, like the significant other was saying this. I'll just lay down with him. We'll just, give him time. Okay, so I tried to say hello to the patient. The patient wanted nothing to do with me. And so I felt he was safe with the family, so I just stepped back, gave them space, stayed close so I could hear if they really needed anything, and started there. So again, like I alluded to previously, time and space is kind of our biggest intervention that we can give these patients and their families, as long as everyone is safe during that time. And so I continued to try to get patient medical history. I really didn't have the ability to do a physical exam because he didn't want other people near him. He didn't want people touching him. But I was able to do a physical exam in the sense that I saw him up and walking. I saw him talking to his loved one. So I knew that like his airway was okay. He was able to walk. He had a steady gait. He didn't need any like a cane or anything. So he was walking per baseline. He was just getting tired. And then I started to try to calm him down too, because the trying to lay with him wasn't working. He was getting up out of bed. He just wasn't going to stay put. And at this point we think, is the hospital really the best place for this patient? What are they going to do for him? And on one hand, well, they'll do a further assessment. Maybe there's something more going on here. But then the family said, he has done this before. It's just not normal for him to do it. Like, it's not necessarily his baseline, So they'd seen him like this before. And his wife actually said, I want him to go to the hospital, but if they want to do like a CT scan and all those tests, I don't want them to do that, and can I tell them not to do that? She was like, I've already done all these things. I know it sounds terrible, but I don't want to keep putting him through this. I just want him to kind of be comfortable and what have you. So, I told her, yeah, advocate for the needs, yeah.
What did they think the hospital could do that they couldn't do?
I think they were scared.
Okay.
I think they just felt safer with having him in a space that could manage him, because to be quite honest, I think they felt that he wasn't being managed at the facility he was at. I
So-
think there was a lack of confidence.
Did
So
the
what did-
family wanted him there? Sorry.
So they were gonna PAM him? I mean, what would the hospital do to manage him?
So they really wanted to transfer him to the hospital so that the hospital could oversee in case of whatever type of interventions for behaviorally that they
Yes.
might be able to assist with?
Exactly. If
Okay.
there was truly something else going on causing this behavioral situation, the hospital would be able to catch that and also manage it. And if there wasn't anything else going on except simply like the idea of like sundowning, right? Then it still felt like he would be safer there. Because the other piece is there are other residents at the facility, and he was wandering the hallway, and due to policies, they can't lock doors. So he was trying to get into other patients' rooms, and so then it becomes like, when is it unsafe, and
Okay.
it just there's
Yep.
Layers.
there's lots of layers. Yeah. You feel it. So we started here. We kept trying with the verbal de-escalation. Oh, so-and-so, how can I help you? What would you like to do? Would you like to go for a ride in the ambulance? Would you like your significant other to come with you? Would you like to sit on our stretcher? Trying to coax them into the direction of the hospital, which is what his POA wanted. And again, continued with that time and space. After about 45 minutes, we had police arrive on scene too because he was getting agitated at that point, and he was trying to walk into patients' rooms, and there's, there's only so much we can do before we're like, okay, you just do what you want to do because it's not safe for us to intervene here. And so because of his increased agitation and lack of response to verbal de-escalation, we did start to work through, we called med direction about sedation. And I am someone, every paramedic has a different threshold. I do not like giving benzodiazepines to my dementia patients or elderly patients in general because they last in their body for a long time, and they may calm the situation, but they have to work through that medication for a while after. So I like to only use it when it's completely imperative to do so. But so we did start at the non-invasive, and then we did eventually consider the more invasive parts. We didn't go to physical restraints, though if we ended up doing our pharmacological sedation, we may have had to do that to actually give the sedation. It's unclear. Luckily, what ended up happening is he connected with a police officer, and the police officer said, hey, why don't you come sit on the stretcher? And he was like, okay. And so again, we gave all that time, and we got the right resources there, and you never really know who that's going to be for a patient. And for him, it was the police officer, and we had the family ride in the back with us just to keep him calm the whole way, and there were no issues until we got to the hospital, and he had to transition from the stretcher to the hospital, right, because that's now another change. But I do believe the hospital in that moment was the best spot for him because they would be able to manage him for the evening, as opposed to the facility who just, for whatever reason, wasn't feeling like they could. Is there anything besides this? Okay, so that's just one example of a 911 call that I've been on where it took us hours to get through that call. But again, when I'm teaching EMS too, I always am very, I really push the idea of this is a human that you are working with. It's not it's not just a disease. You need to understand the disease, but you need to also treat them like a human. And so jumping to tackling them down and getting them on the stretcher because that's what family wants you to do, that's not going to be best medical practice. But that being said, we do have some areas of growth, I believe, in our EMS curriculum at a national level. I need to do some research as to what exactly the percentage of our behavioral health calls have to do with dementia. We don't have that drawn out specifically with our state numbers right now, but I think it'd be really interesting. And I do think that there's space for us to add something in our curriculum that says the word dementia. But if anyone has any questions or resources, please.
So what could be in that protocol for dementia?
Yeah, I don't even know that it would be a protocol change so much as it could be a curriculum enhancement. I think maybe understanding the pathophysiology of the different diseases that fall under dementia could be beneficial for a provider to connect maybe even with a patient, and to just like better understanding, I think, leads to better patient care.
Well, that, yes,
Yeah.
definitely.
Yeah.
It's like a stepping stone of the educational pieces that we've kind of encompassed throughout the day. Like myself being a case manager, but then in the caregiver role too, holding the education and knowledge firsthand in order to be making informed decisions or make informed calls. Because when you're looking at the 988 and you're looking at those mental health components on top of a symptom of, or an individual who is really progressing in their Lewy body dementia, and they live in rural Vermont and no natural supports, and is very, and has reached the stage of a lot of hallucinations and paranoias and whatnot, and then working together. It's a lot, and it takes a lot of time and a lot of team members, and as you were saying, it's kind of an exhausted. There's not a lot of people, you know,
Right.
so I commend you for doing it, I appreciate it.
I find it even more difficult. Vermont is a very prideful state,
Yes.
and we have so many elderly that want to stay in their homes.
Yeah.
And the families are, you know, often having their own families and just disconnected. And I think those are the individuals I struggle the most with, because you walk in and you see them and you recognize that something needs to be done, but it's hard, right?
Yeah.
We can't take people against their will. Law enforcement can't, even more so now that there's a new use of force policy. We're not getting a mental health or an officer response for mental health. It's hard, I mean, right? We're all human, and sometimes we're like, all right, you're alert and oriented, you can make your own decisions. Don't think you should be home alone.
Yeah.
But they're allowed to make crummy decisions.
Yeah.
Yep.
That's
Yeah.
just the thing, and it's really hard to like find it within yourself to be comfortable with that,
Yeah.
with your own little ethical moral compass of like,
Yeah.
no, but really you should have this support. But
It's
now I
there
have to
for
call
you.
your child who's across the country
Right.
and hope that I can get them.
Yeah.
You know, and no, sorry.
Andy, what's the percentage of people with dementia or Alzheimer's who live alone?
Yeah,
It's
like
like
Vermont, it's like a third
A third. Wow.
too.
And that's just what we have been able to assess.
Yes.
We don't, that, you know,
That's right,
that's.
because they underdiagnosed.
Exactly,
Yeah.
which has got to be huge because of our, we are very, you said that so well, and then,
Yeah.
and a lot of people do not want to work with, you know, our typical medicine and get that, you know.
Well, so we kind of talked about putting this in the presentation, but we didn't. So I think something to maybe bring back to your agencies and to think about is nationally, and I think both in the state level, we are starting to look at mobile integrated health.
Yeah.
Yes.
So that's the paramedics coming in a non-emergent situation and providing care and treatment before we get to the situation of 911. Obviously, there's so many different aspects of that: reduced healthcare costs, benefit for the patient. And I personally think it would be something that's going to be very beneficial to communities, and in my town, that is something we're looking at. But maybe just something to keep in the back of your guys' minds, and
Promoting it.
yeah.
Yeah.
It may be that an agency will reach out to develop some kind of a partnership or referral system.
That would be beautiful. I mean, we already have it for, I mean, when we look at primary cares and we have our integrated social workers at this point. So what,
Right.
I mean, where's the grant? Where do we write this? Like,
Yeah.
Yeah,
let's go.
Yeah. Yeah.
Oh, I was gonna say, I was talking to Mag Polite at lunch, and does the Alzheimer's Association have some training for EMS?
Yes.
They
Yeah.
do?
Yes,
believe
the
so,
national
yes.
organization does have training tailored for emergency responders.
It's like an online, I think I took that one.
Oh,
Yeah,
did you?
online,
I'm pretty sure I did, yeah, I
like
can't,
a year or two ago.
okay,
Oh,
yeah.
okay.
Is it worthwhile? Yeah.
Is it too basic?
It's pretty basic.
Okay, I'll get feedback because I think.
I'd have to review it, to be completely honest with you.
Yeah.
It's-
I mean, it's a starting place.
I'm
Absolutely.
curious.
Starting.
I'm curious what that
Yeah.
would look like outside though. So for like in my realm, right, in case management, in a AAA.
Yeah.
You know, obviously we have a ton of resources and we connect in general, but where it might hold benefit for our AAAs to just hold this training as well as we are also serving. I mean, if you look at option counseling, they're like first line out there to connect with people.
Right.
Yeah.
I don't know. I don't know.
That's a great idea.
I think it's
Thank
a
you.
good.
And we would then welcome your feedback.
I'm curious. Yeah,
Yeah.
I would love to stay connected with this. Yes.
Yeah, okay.
Yeah, and I would love to.
Go for it. Write the grant.
I know. I'm like, oh, okay. We're gonna sign that up. And next grad class will be grant writing.
I was just wondering though, with and maybe Maureen, you know, is with a mobile integrated health model, is it one that it can be, I mean, it would seem ideally that we have a consistency in capacity across the state for emergency response. I'm in Virgins, I hear from our local VARs, you know, that it's a real struggle to have enough human capacity because we had historically in Vermont relied so much on volunteers,
Yeah.
right? And it's expensive moving to a professional model. But do you think like the integrated health, mobile health model could be funded in a certain way where you don't have to write grants? You can take the 5, you know, top causes of whether it's, you know, lack of mobility or death or combined, and that's integrated into the system of care through EMS.
I
Through
think
like
that's,
insurances and such.
Yeah, like it's,
I think it's definitely a possibility, right? So mobile health, it focuses on preventative care, right? So some of the things is like just safety checks, right? Is the shag carpet right before, by the bathroom
Yeah.
that you keep tripping on a safety hazard? Maybe if we move that, you stop calling 911 because you keep falling.
Yeah.
But I think anything preventive falls into that realm. It's just a matter of how do you develop a partnership between the agencies that are really good at it and can make. So think of it as we're kind of like the eyes out in the field. We're still reporting back to someone, whether it's the hospital, an outpatient clinic, or maybe it's mental health services, that, hey, this is what we're seeing. I think you should look into it. But does that kind of make sense?
It does and doesn't. I guess I'll go back to dementia because one of the things that can happen with a cognitive impairment is paranoia starts to impede, I think, home visiting. And if you have two, like also is that it's very hard to have too many people.
Yes.
And so I could see like having a trusted unit, and this is what I also hear somewhat locally is, I think one of the reasons that people do call when it's not really an emergency, but who do they trust?
Yeah.
Is their local response.
Which is a big responsibility.
Yeah,
Yeah.
it is. And so I think it could work well for helping people to stay in their home longer because we're not going to have enough beds
No.
in our state, and it's really hard on families and hard on the person when they're sent out of state.